Good evening, everyone. Let me welcome all my viewers once again today on Beyond Sugar. आज शाम के इस लाइव प्रोग्राम में आप सभी का स्वागत है. Beyond Sugar is created for all of you, and this platform has been created in scientific collaboration with RSSDI and Indian Society of Nephrology, ताकि आप सभी तक सटीक इंफॉर्मेशन, साइंटिफिकली करेक्ट इंफॉर्मेशन पहुंच सके और आप अपनी डायबिटीज और उससे रिलेटेड कॉम्प्लिकेशंस को लेके सचेत रहें. ना सिर्फ हम आपसे डेली बेसिस पर इंफॉर्मेशन शेयर करते हैं, बट आपसे बात करने के लिए वी ऑल्सो इनवाइट लीडिंग डॉक्टर्स फ्रॉम अक्रॉस द कंट्री who can talk to you who can talk to you as a friend directly and answer your questions as well. So Aj, in the same context, I am very happy and very glad to welcome Professor Anil Bansali. Sir, welcome to the show.
Thank you. Thank
So
you,
we keep
Sanjeev.
on We keep on getting a lot of chats from you, questions about how elderly patients need to take care of diabetes, and largely there are two situations, where someone is having diabetes and then he is entering the older age, and then second is people who get the new onset of diabetes in the elder age. But we will take all your questions. और उससे पहले I'll be very glad to formally introduce Dr. Bansali to all of you. He has been a globally renowned endocrinologist and very well respected doctor in our country. Not only as a doctor, but also as a medical teacher who has trained many endocrinologists across the country who are working today. In fact, he has been going to various global universities also for as a visiting faculty, but he is more known for his stint of more than 3 decades in PGI Chandigarh, where almost out of that time, 18 years, he was head of department at endocrinology department. Sir also has more than 600 publications and research papers to his credit, and he has treated lakhs of patients. He has many awards to his credit, including the BC Roy Award. So he is an institution in himself, and we are very happy that he is here today to talk directly to all our viewers and patients. So with this, let me straight away invite you and for your opening comments on this topic. And today we'll discuss about diabetes and elderly. Over to you, sir.
Yeah. Thank you, Sanjeev, for very kind invitation. And I'm happy to be here. And I'll be very happy to talk with the people that particularly we are going to talk on a topic which is going to be highly relevant in future, in fact, and even in the present days, where the people with diabetes who are elderly, say around 65 plus, that's a standard definition of the elderly population is taken into consideration. So this population really requires attention. This population poses a challenge in the management strategies because they are behaving absolutely very differently than the younger people or younger population. And you will be very surprised to know that the only 8% of the people in our country are able to cross the age of 65. So that's a very low figure so far. It's very disappointing to know that when I reviewed, and I found that only 8% of people are able to cross the age of 65. However, in Japan, the highest number is that 25% of people are above the age of 65 years plus. Somewhere in China, it is around 12%. In US, it is around 18%. So India is in a very lower. So it's a very lucky that if you cross the age of 65 and then you see that, so that's a very important that these people, if they do develop diabetes or if they are having a diabetes and enter into the age of 65 years onwards, then they poses a different challenges because by that time they do accumulate a lot of comorbidities, complications, many of the risks which we are going to discuss. So it's a very special set of people who really require attention by the not only by the endocrine, but they require really the multi-specialty care as well as they do require the good family and a social support. That's a very important because these people are having a lot of disabilities or functional disabilities or neurocognitive disabilities. That's why they require the support of the so many people in their care. So I think this will be very interesting when we'll proceed for the talk and we'll give more and more information to you.
Yeah. So thank you, Dr. Bansali, for your opening remarks and telling us this important statistics. Although it's quite surprising that it's a very less number of population which cross that age of 65, but then they are, as you said, very very special. Sir, as compared to the younger population now who get diabetes, now what are the some of the unique challenges which elder age group patients face while they have diabetes and in managing their diabetes?
Yeah. So I think the elderly people, they usually behave like a children. So they may not listen to you. They may not follow the given instructions. So you have a lot of things which they usually have a problem. The another thing which they do have, because by the time when they really enter into the elderly age, they do accumulate a lot of complications. So many comorbidities they do have. So they might be having a coronary artery disease by the time someone definitely would have had a stroke or a peripheral vascular disease. Someone would have had definitely many people are having a hypertension. So the lot of comorbidities they do already accumulate, and they do have a lot of functional disabilities also, which the younger people they don't have naturally. And in addition, they are very much predisposed for hypoglycemia also. As you advance with the age, there's a more tendency or more predisposition to have experienced the hypoglycemia also. And then the monitoring, and the majority of people require the insulin by that time, so they don't easily accept the insulin easily one. Then newer technologies which are easily employable in the younger people, which you are not easily getting through the elderly people also. And all the glycemic targets, blood pressure targets, they are have to be redefined for this aging population. And in addition, the good social support, good family support is also required to take care of them. So the elderly people they do behave in a very different way than the younger population, and suddenly you have got more challenges for these people to support their disease.
So I think these are quite a few challenges, which you have shared, which elderly people may face. Starting from you talked about the redefined targets to hypoglycemia to so many comorbid situations. So let's start by the target values only. So let's say if in younger population the target values are lesser. So what are the target values which elder people should be aiming for, or which you guide them to aim for?
Yeah. So for a younger people, like say for a hemoglobin A1C, it should be below 6.5. And even if someone is yes, and some societies and guidelines they say that even you go up to 6. But for an elderly population or these individuals, the targets are usually between 7 to 7.5. And if they do have really so many comorbidities, the target even can be relaxed up to 8. So the normal or the younger population, we are striving for 6.5 or even below than that, without definitely causing hypoglycemia. But in an elderly population, just to visualize it, we make it around 7 to 7.5 or even up to 8. So this takes care of the, because though so many comorbidities they do have, so they are at a more risk of hypoglycemia also, so that can be taken care of. In addition, the glucose targets they also go down. So, like the we say the fasting glucose or any pre-meal values for the younger population is 80 to 130. But here we take it around 80 to 150. So we or even 100 to 150. So I think the targets are usually redefined for these individuals. So the risk of hypoglycemia can be minimized. They should never experience it, or they should minimally have a hypoglycemia in any way. In addition, the blood pressure targets. The blood pressure targets for younger population is in a diabetic we say by 130 by 80. In an elderly population or in a population say above 65 plus, even the blood pressure targets can also be relaxed. The lipid targets, I think, try to maintain the same LDL cholesterol below 70, and let's say we usually strive. I don't think there's any change in the lipid targets. So the blood pressure targets, the glycemic targets, both blood glucose and hemoglobin A1C, and the targets can be further relaxed if someone is having a more predisposition for hypoglycemia. Say someone is having hypoglycemic unawareness, or someone is having a recurrent hypoglycemia. then targets can be further relaxed. So targets change, it has to be individualized. And in addition, we have to take care of the other. So we have to focus also on their you can say that their lifestyle modification program. So more focus on it because they do have a more propensity for sarcopenia. Their muscle mass is also quite lost. So we have to have very different kinds of the dietary intake. The protein intake should also be taken care. We should also talk about the some resistance exercise which they give. We'll talk more about the exercise part and lifestyle modification part. So the things are focused in a very different way in these elderly population.
Okay. तो आई थिंक these are very important and I'm sure जो viewers हमारे सुन रहे हैं इस program को या बाद में भी देखेंगे. So as compared to younger population, your targets for blood sugar, for blood pressure, so keep it little higher. Your doctor will keep it little higher, and the numbers which Dr. Bansali has shared. So maybe it is 10 to 15% more relaxation as compared to younger population. That's the largely the crux of it. Sir, you also mentioned about other comorbid situations like so now the maybe the primary reason for those comorbid situations like a kidney problem or a heart problem or that the primary reason may be diabetes and a patient will be following up either with the endocrinologist या फिर वो अपने physician से treatment दे रहे होंगे तो ऐसी situation में what is the guidance for your elderly patients कि कैसे वो screening करे या आप उनको क्या do you send them to other doctors other specialists as well for routine checkup so what is the general advice and protocol you follow.
Okay. So the complications in the diabetes is basically a function of increasing duration of disease. So I think the most important determinant for developing the complications in diabetes is the duration of the disease. If someone has already had, say, 30 years or 25 years prior to the age of 65, and by that time they become 65, they do already accumulate a lot of complications. And even someone is having a disease even at the age of 65 years, they will be predisposed to develop complications faster. The reason for that is because as you advance with the aging, your vasculature, because the diabetes is basically disease of vessels, so your vasculature is already at a brink, and you develop faster these complications in a later age. So it's a duration of disease is very important determinant. It's how the glycemic control has been maintained in the previous years. That is also determining the complications in the later stages because that's what we call as a legacy effect. If you have a good control of a diabetes in your early days of the initiation, early days of the diagnosis, or early days of the disease, you do much better even later, even you relax your control of the disease. As opposed to those who never had a control and they try to control later, they do suffer more from complications. So the screening protocol as that like we do an annually for the neuropathy, retinopathy and this. And for a cardiovascular disease, I think they make an additional approach there. And now the guideline says that every patient should have an ECG, that's one, echo should have. And yes, the other methods like a CT angio or a coronary calcium score can also be done. But the all other things like angiography and all, they are only recommended if the patient is having any symptoms. If the patient is not having any symptoms, then you don't require a workup beyond the ECG and echo. So, but you have to be very cautious. It is a part of it, and I think one thing very important which I just wanted to highlight: foot disease. The diabetic foot disease is also a growing problem. The majority of people with diabetes, they do have a predisposition for a diabetic foot disease with the increasing duration of the disease. And they say around 40% of people, they do have a neuropathy and they develop some or other complications of the foot. So foot should also be taken care very well and they should also go for a annual foot screening program. So at least they can take care of that part. Because many people we see now in our clinical practice who are elderly and also having a concurrent peripheral vascular disease, concurrent cardiovascular disease, and they come with the gangrene of the foot. So I think that part also should be taken care of. So foot is another problem. The another problem is because the elderly people once they reach, then they should also have a screening for or suspicion for the diabetes. So diabetic people, in fact, our own data we published many years earlier, we didn't show that the CA pancreas was more in people with diabetes in India. We showed that the CA breast was more common in women, and the CA, and I think the lung was more common in men. But certainly, we should also have a watch for the as a part of the annual screening program, even for a malignant disorders. In general, in diabetes, they do have at least two fold higher risk for malignancy. So that also is should be taken into account.
Okay. So I think that's very elaborately Dr. Bansali has explained to us. One thing very importantly, he told us that there is a legacy effect in diabetes. So eventually, agar diabetes hai, so complications will arise in the organs. But in your early years of diabetes, if you have managed it well, you have kept good control. So maybe later on in the age, these complications will be delayed or they would be lesser. Uh, and vice versa is also true. And I think he emphasized the importance and role of screening, that after the particular age you must screen for these 4 or 5 things he mentioned on an annual level, so that it can be detected early by a doctor and treated as well. Sir, you also talked about initial comments made about the hypoglycemia incidents may be higher, and it's a risk. So one strategy is of course that कि आपने थोड़े रिलैक्स किए targets for their blood sugars. So are there other strategies also which people should be aware of कि hypoglycemia को कैसे वो reduce करें, or especially in the elderly age group, the night time hypoglycemia which can be very fatal, how these things are taken care of?
Yeah. So I think it's a very important and very pertinent question that hypoglycemia is the one of the killing. Uh, you say that disorder for the people with elderly population. Even sometimes they may die because of the severe hypoglycemia. They will develop neuroglycopenic symptoms. They will develop cardiac arrhythmias, or even they may develop stroke. So one is that whenever you find that someone is having a hypoglycemia, you first assess whether it is a recurrent, and secondly whether it is associated with hypoglycemic unawareness. If they are associated with recurrent hypoglycemia, find out the cause, whether it is a missing the meal or a mismatch between the meal intake or the oral tablets or insulin injections. Secondly, if they are having an unawareness, then best is to first to relax the targets. After relaxing the targets, you can also put a dietary modification program. So give at least carbs more frequently with them. And then they may require CGMs. If they accept it, I think put a CGMs to them so they can be taken care of. And if they are on insulin, choose at least those insulin which are having a less predisposition for hypoglycemia, particularly long-acting insulin. So like newer insulins like Largin and Dibulan, they have been or even U300 larger, so that they have been shown to reduce the having a reduced episodes of hypoglycemia overall as well as an actual hypoglycemia. So our changing and then long-acting sulfonylureas like glimepiride and all should be avoided. We should take care by you require so many modifications if they do develop hypoglycemia. So one is the dietary change, targets are relaxed, CGMS can be provided to them just to monitor it very carefully. Should be taken care by telling them how to combat hypoglycemia immediately. If required, maybe having a concurrent glucagon with them, so I think someone can quickly inject, and then you take care that it should not recur. So you can use the long-acting insulin analogs and the newer analogs like the short-acting, like a fast-acting insulins. So and the avoidance of sulfonylurea, choose more DPP4 inhibitors as well as SGLT2 inhibitors. So I think so many strategies are there now to prevent or at least to reduce the number of hypoglycemic episodes in these individuals.
Yeah. So I think he explained to us again like what are the strategies, and some of them कि खुद patients उसका ध्यान रख सकते हैं. And I think some of the things he mentioned also doctors, and physicians, family physicians should be aware of. But I think from patient's perspective, it is very very important that you should know how to identify and immediately what measures you should take अगर आपको low blood sugar होता है. And finally, don't ignore it. Whenever you face any such incident, inform your doctor also, so that he's aware that you have faced hypoglycemia and he makes the required changes in your therapy. Sir, a lot of people they ask for that. What's the advice in elderly patients with respect to the nutrition? What kind of diet they should be taking, and what kind of exercise or lifestyle modifications they should do. Especially, at that age, some of them may have some pains in the joint. Some may have restriction issue, movement restrictions. So, how do you advise the patients and our viewers on that?
Yeah. So I think with the advancing age, and particularly when you have got to concurrent so many comorbidities, and the functional disabilities, they progressively increases in age. And secondly, there's a remarkable change in the body composition in increasing age. So your muscles are basically replaced by the more fat tissue. So you do usually have a sarcopenia. So this sarcopenia contributes to more functional disabilities. So that's a one. And to overcome this, I think there are some changes in the nutritional part of the people with elderly population. So at least the your protein intake should be zero point 0.8 to 1 gram per kg per year. That should be taken care. And these amino acids, and we should ensure that they can be incorporated into the muscle. So they should also be trained for some exercises which can help in incorporation of these proteins. So particularly the resistance exercises, to some extent, to these elderly people may be talked about. In addition, yes, the intake may also be erratic. So at least we should always tell that if they have already injected insulin or if they have already taken the oral hypoglycemic tablets, don't miss the meal. So first is they don't should not miss the meal. Secondly, the dietary components, particularly protein, should be taken care. The the your part of the exercise part. Yes, the brisk walk or usually the walk is the best exercise for the elderly people. And in addition, they should also take care of that part that they should some precautions in general because we have seen many patients they do have a hearing disability and they are not putting a hearing aid and getting accident. They are also going alone for a walk early morning. We always say don't go for that because many people have been bitten by the dogs. In addition, they also take care, they should preferably go to the park and do the exercise there. And they should also not do the like a very early morning walk. Many people they go at 5 o'clock in the morning. I think that should also be avoided because extreme exposure to winters like that. Many people they do have a coronary event. So I think there are general precautions which can be taken for that. So the walk is the best exercise for them. One. Secondly, if they can do brisk walk, that is all fine. And protein intake, we have already talked about that. Some nutrition supplements and vitamin D supplements should also be taken care. And elderly people require relatively higher dose, so vitamin D should also be taken care. Some stress on the resistance exercise and variety of exercises we can be taken care. So you can they can do some push-ups or sit-ups or a very light gym. I think that can also be taken care of the part of that. And there are many people they ask about the alcohol and all. I think no more will not talk much about the controversy, but yes, if they are having this, then they can have a limited amount of alcohol as well. So I think these are some modifications they do really require, but it doesn't mean that elderly people. And yes, the many people prefer to do the your pranayam or yoga, but certainly the very severe stretching or strenuous exercises should be avoided. So they should not break their spine or they should not break their ligaments because unnecessarily if they fall, again they will have more comorbidities and a very prolonged illness or prolonged duration of critical illness. They will have. So I think these things can be taken care in these individuals so the life can be smoother and they can maintain the good nutritional status as well as the good functional abilities.
Oh, thank you, Dr. Bansali. I think very, very practical tips that what elderly people can do and what they should avoid also. And such practical tips can actually come from someone who would have maybe treated lakhs of his patients in his overall tenure. So he also talked about the times to which you should avoid. Don't go early morning. Avoid areas where you can even go for a or face a dog bite kind of things. Very, very practical. Sir, what about when someone is in the elderly age group, there are other age-related cognitive issues as well. Like, someone will have forgetfulness kind of things. He has a long list of medicines to take. 7, 8 medicines is taking, comorbid situation we have. I mean, people forget at times at that age, or people who are taking insulin. I've taken, seen simple things that someone is not even able to close the needle of, the cover, needle cover and things, and they injure themselves. So, what's your advice, on these issues to your patients?
Yeah. So I think a very important point that elderly population they do have a neurocognitive decline with advancing age. And this neurocognitive decline is basically can lead to so many problems in these patients. Sometimes they may re-inject insulin. Sometimes they may take a tablet twice. Sometimes they have taken the tablets but they forget to take their meals. So that's why now the recommendation is that the people above the age of 65 years have an annual assessment for the neurocognitive function. That's one. I think which is and recently when I was reviewing, I just found it very interesting. If someone remembers that I have forgotten something, it's an age-related decline. If someone does not remember that he has forgotten and reminded by others, then it's a disease or it will be dementia. So I think it's a very important that if you remember that I have forgotten this thing, means it's age related. Means you know that you have forgotten. But if someone reminds you that you have forgotten, then it's a disease process. And we know that the people with the diabetes, they do have a 2 to 3 fold higher incidence of dementia. And now the people call it as even a type 3 diabetes. In a type 3 diabetes, there is a cerebral insulin resistance. And so the brain tissues are resistant to insulin action, so the glucose uptake is reduced. So that's why the people are now it is calling as a type 3 diabetes because it is also very common. The another disorder which we also commonly see in people with diabetes is Parkinson's. And we are seeing a deadly combination of a Parkinson and dementia, Alzheimer's together. So I think that's a very, very crippling, lot of functional disabilities, a lot of responsibilities by the to be borne by the family members and our social family. So I think so that's why the annual screening for that. Then you would require a behavioral therapy, would require a consultation by the psychologist. So many things and so many people are involved in their care, so they can be taken care. And you have to take the special precautions for that, like putting injection twice or taking tablet twice or missing their meals. I think they may require reminders, they may require alarms to take care of that. But it's a very, very important that the people with diabetes, they are at a very high risk for 2 to 3 fold higher risk for developing dementia. And if they combine with the Parkinson's, I think the things become more worse. So that should be taken care into mind. Yes, but I think I can also tell you is that if you maintain your a good glycemic control, as a part of the legacy now, the people are also showing that those who maintain their good glycemic control for a pretty long time, the the risk of dementia is not increased as opposed to those who are uncontrolled diabetes. So I think that's a very good point is that you try to maintain a good glycemic control from day one of the diagnosis of the disease. So even when you become elderly, you don't behave like an so you still behave like an adult, young adults. So at least so many complications can be avoided because even in an older population, the problem is the accumulated or cumulative comorbidities. So all can be curtailed by your past if it has remained good.
Yeah. Again, I think he mentions about the legacy impact, and there are a lot of, if people tend to forget, newer technologies coming in these days. There are pill boxes. They can send reminders on your mobile phone, and multiple things can happen. Sir, what about you talked about the role of family, and then, at this age, a lot of psychosocial issues may arise, emotional well-being, the goodness of that. So, what's the role of, how the family can support here, the friends can support here? What's the importance of, the social linkages here in this age while managing the disease?
I think what we have seen in the previous decade at PGI as well, the social fabric or the social support or the family support is also breaking down in our country. And in many elderly people, their children were too busy or their children were in the abroad. So they were all alone and coming alone. So that's why I think shared with you is that we started the elderly clinic after 2 o'clock in each year with a very special permission from our director at that time. We asked for that. The elderly people, we can call them. They can have registration at 3 o'clock. So they used to come after lunch, and then they go back around 5:30 or 6 o'clock. So these people, yes. So in our even a system, we always believe that the Indian system is very different as opposed to the Western culture, and the people and the children might be supporting their parents, and they at least now the people are too busy one, so that's why they are not able to bring their parents. They might be arranging, but they may not able to come with that. So I think that should be. I think the family support is very essential. It is very much required, and I would suggest that the children, I think, must take care of their parents in that. The government cannot take the responsibility because we don't have insurance system. So, but still the social support that is also very important because we have so many societies even in Chandigarh where the people are available to support. So I think that trend is I think rising. That's a very solacing and consoling us is that some people are available for the social services. So I think you certainly require a good social support, a good social fabric, as well as the family support to take care of these individuals. Otherwise, these people unnecessarily suffer. And again, because once even I have a single episode of hypoglycemia, that may lead to more comorbidities or even kill them. So I think that's and it is the social support also with a lot of emotional well-being because the overall the happiness in the life is a partly even you might be having a disease, but if you are emotionally well, you are able to tolerate so many things. You are able to overcome so many challenges. So I think that's why the society has to understand, the family has to understand, the children has to understand to take care of their children and like our Indian tradition, Indian culture, where the children are supposed to take care of their parents. And I think this was a trend earlier, but the trend is breaking down, and I hope the people will be more aware in the future, and our society will also give a lot of support.
Yeah, so that's a message for family members as well. Your support is very important in these cases, and you must support elderly people in this. They need that assistance. So you talked about good glycemic control. You talked about hypoglycemia as well, and regular screening. I just wanted to ask you this thing that daily blood sugar monitoring. Many people they keep the glucometers also with them to avoid high blood sugars or hypoglycemia. So what is the advice in elderly patients? How regularly they should be doing that blood sugar levels for them?
So I think if yes, if we are our targets are relaxed, and our main aim is neither they should have a hypoglycemia or nor they should have a go into any metabolic crisis, particularly severe hypoglycemia. So if the elderly population, if they are on oral hypoglycemic agents, and if they are maintaining their hemoglobin levels to between 7 to 8, they can do at least 4 to 5 times or 4 to 6 times blood glucose profile, uh, even in a month. It's good enough. So OHA, those particular because the OHA also we give a OHAs which are beta cell friendly. We don't use a sulfonylureas like which are very long acting like given that we certainly out even your glimepiride. So we use the sulfonylureas now lesser. We use preferably more DPP-4 inhibitors, metformin, and SGLT2 inhibitors to some extent. So I think that can be easily taken care of. So we can do even a 6 point or a 7, 8 point maximum say. So even in a month, if you do that, that's a good. Sometimes you do fasting, sometimes you do a post breakfast, post lunch, and post dinner. So I think that gives fairly gives an idea. So 8 point profile in a month is good. But those who are on insulin, I think those who are on a single pick insulin and maintaining their like glargine like that, maintaining their fasting sugar in a normal range, at least they can do once in a week their profile, and that's a good enough. But those who are on a basal bolus, they may require at least 3 to 4 point profile, at least fasting, post breakfast, pre post lunch, and post dinner. These 3 4 values may be required those who are on baby bonus. So relaxations for a single trip, relaxations for the people who are on overseas, but certainly not relaxations for those who are requiring multiple injections. And in addition, the hemoglobin A1C once in 3 months, I think that should ideally be done. And blood pressure monitoring, yes, they should look for a self monitoring of the blood pressure, and at least 2 to 3 values in a week time is good enough. And the same, I think, the rest of the biochemistry. Yes, those who are having a renal dysfunction, they may require it. They suppose that they may require a EGFR estimation and urinary albumin creatine ratio at least once in a 3 month if they are really requiring the intervention for that. So I think things changes with the concurrent comorbidities in these individuals. If they do a lot of comorbidities, then you require certainly more rigorous. Otherwise, but yes, and many elderly people they may not like to do prick many times. I think that's another reason for that. So I think but they should have a device with them. That is very, very important. So even if they do have a hypoglycemia, they are all alone. At least they can do sugar and can ingest the glucose and glucose-like substances. So I think that should be there.
Yeah. No, I think that's the subject very well covered. Although I know that this is a there's so much to discuss on this topic, that how do elderly patients they have to take care of their diabetes. I must thank here Dr. Bulsali. You, I think you have covered each and every aspect of it. I know due to the shortage of time, we may be missing out a few important things as well. Uh, but finally, sir, your word, as a summary or something very important which we may have missed, you still want to emphasize that how do the elderly age group patients they feel empowered that they can themselves participate along with their doctor to manage their diabetes well.
Yeah. So I think all elderly people, well, they should be very grateful and thankful to the God that they have survived till 65 years of age. So it's a God's grace that you are able to see the day up beyond 65. Secondly, even if you have a disease, since you have fought the disease for a pretty long time before you become 65, so meaning by that you have taken care of the disease very well. So otherwise, had you not taken care of the disease very well, you would not have survived till 65. So like many type of diabetes, we don't see that they are surviving till 65. So first is very thankful and it's a highly gratitude to the God that we have lived beyond 65. Even if you have a disease, we have survived the disease for such a long time. And we do require the understanding of a disease. We do require a continuous support by your family physicians and doctors. We do require a good support by the family members, and the social support is also required. And you also need money. I think more and more insurance companies and more and more, I think government should also do that. A lot so these people can be taken care because they are assets to the society. They can contribute by many, many positive things in the society that can be for the betterment of the society as well as for the country.
Thank you, Dr. Bansali. So, on this positive note and the positive strings which he has given to everyone in the end, I think we are good to conclude today's session. I must thank all the viewers who watched us live or who may be watching this program later on as well. If you have anyone in your friends or family circle who is having diabetes, who is elderly, you can simply share the link of this program with them. This will stay here on the Facebook page as well as on the YouTube. They can always listen to Dr. Bansali, and I think this conversation can be very, very useful for them. So, with this, I thank all my viewers. Dr. Bansali, thank you so very much.
Thank you, Sanjeev. Thank you
You
for
took out your time.
very nice interaction we had, and I hope the people will enjoy it.
Yes, sure. Good night and take care.